All right, chapter 21, anaphylactic reactions. We're going to go over the pathophysiology of allergic and anaphylactic reactions, the assessment, care, what epinephrine does, all that good stuff. EMTs Luke and Joy arrive at Armstrong Elementary School for a report of an allergic reaction. 6-year-old Jessie began having difficulty breathing with weakness and a rash within a few minutes of the accidentally being exposed to peanuts, to which he has a known allergy. EMTs see a boy sitting in the nurse's office with swelling of his lips. They can hear wheezing without a stethoscope. What does that tell you? Yeah. What level of concern should they have based on their general impression? He's sick, not sick. He is sick. What is going on in the patient's body to cause his signs and symptoms? Okay. All right. What steps should be considered in formulating a treatment plan for this patient? What?
See if he has an EpiPen.
If he has an EpiPen, that's good. What else?
Call the trainers.
That's the school should have done that when they called you. But however, you're right. You are right. Anybody else? Yeah. All right, an allergic reaction is a hypersensitive reaction resulting from exposure to an allergen, which can occur at any time to anyone. A wide variety of substances can produce such reactions. Food, medicine, insect stings, and even exercise are common causes. I'm allergic to exercise, just so everybody knows. An allergic reaction can be mild, localized reaction presenting as redness, itchy skin, and edema, or a mild systemic reaction resulting in widespread hives, also known as urticaria. In its most severe form, an allergic reaction can cause a systemic, multi-system, life-threatening condition with respiratory failure and circular collapse and shock. This severe reaction is known as an anaphylactic reaction and also known as anaphylaxis. Okay, so this is what I want to point out. There is a difference between an allergic reaction and an anaphylactic reaction. Okay? An anaphylactic reaction is a severe, exaggerated, systemic allergic reaction that is associated with severe swelling of the upper and lower airways, constriction of the bronchioles, leakage of fluid from the capillaries, systemic vessel dilation, and an increased production of mucus. An anaphylactic reaction can be so severe that the upper airway closes. The respirations become labored because of high airway resistance from swollen and constricted bronchioles. And the blood pressure becomes dangerously low because of the dilation of vessels and leakage of fluid from the capillaries. A delay in emergency care can easily and rapidly lead to deterioration in the patient's condition and even death. All right. The immune system responds to foreign substances called antigens. Allergens are a type of antigen that can provoke a reaction in some people. The response of the immune system upon exposure to an antigen is to produce antibodies. This immune response typically occurs with little or no allergic reaction. But sometimes your body goes a little haywire. Okay? An allergic reaction is the abnormal reaction of the immune system to a foreign substance. The reaction can range from mild to life-threatening. The chemicals released in anaphylaxis result in swelling of the airway, bronchial constriction, and poor perfusion. Anaphylaxis requires a prior exposure to the antigen. An anaphylactoid reaction is similar but does not require prior sensitization to the substance. Penicillin, bee venom, nuts, and berries are common causes of anaphylaxis. An antigen can enter the body through the skin, the GI tract, or the respiratory tract. When it does, it sets off an immune response in which the immune system detects this antigen and produces an antibody. Antibodies are proteins that search for the antigen, combine with it, and help destroy it. Okay? So, your antibodies is like your body's military. And it's going for that terrorist. Okay? An allergic reaction is a misdirected and excessive response by the immune system to an allergen. The allergen is usually harmless to the patient, and most allergic reactions are mild, producing nothing more than discomfort such as itching, a runny nose, watery eyes. Results from the body's attempt to eliminate the allergen. Once sensitization occurs, the patient is primed for a possible anaphylactic reaction. It can take several exposures for a foreign substance over a long period to become sensitized. Okay? This actually happened to me. I'm allergic to all insects. When I was in paramedic school, I pulled a muscle in my back when I was doing like PICU clinicals. I don't know how I did it, but I did it. Went over to the clinic at UMC on campus where they staff like doctors learning stuff. They gave me a shot of Toradol. Went back, taking my oral pharmacology final. My face starts itching. I'm like, well, I'm just nervous. Sitting across the desk from one of my professors, and I'm having to give all this information because he said about 5 words, and I had to come up with this big long paragraph full of stuff. Face is still itching. I'm like, okay. He never says anything. So I get out of my pharmacology exam. One of the other professors looks at me, and he's like, grabs me by the wrist, and he's like, do you have any problems breathing? I was like, yeah, but I just thought maybe I was nervous. Yeah, my lips were swollen, I had hives, my whole face was red. I could hear myself wheezing. He took me straight over to the emergency room from a Toradol shot. So I cannot take Toradol, cannot take any kind of NSAID, cannot take aspirin, ibuprofen. I have a headache, stomach ache, toe ache, it's all Tylenol. Yeah, it really sucks. Because you can't take like naproxen, you can't take anything. I know. I've been eating them like candy the last 3 days because my head hurts. But, however, head's not hurting right now. My liver's kind of feeling funny. Alright. Anywho.
Washing it down, monster.
Yeah, for real. I am healthy. When the antigen is reintroduced into the body, it attaches to the IgE antibody that are now located on the mast cells and the basophils. Granules located inside the mast cells and basophils attach to the cell membrane, allowing them to release their contents, which are chemical substances known as chemical mediators, into the interstitial fluid. Once they are outside of the cell membrane and the interstitial fluid, these chemical mediators can be picked up by the capillaries and transported by the blood throughout the body. The primary chemical mediator released from the mast cells and basophils is histamine. Now everybody knows why Benadryl is an antihistamine. Okay? Histamine causes bronchoconstriction, vasodilation, and an increase in capillary permeability. After the chemical mediators are released, the mast cells and basophils regenerate the granules inside the cell membrane, priming them for another allergic or anaphylactic reaction. The life-threatening response that are directly produced from the release of chemical mediators are bronchoconstriction, increase in capillary permeability, and vasodilation. These produce most of the signs and symptoms seen in anaphylaxis. In some reactions, the chemical mediators can be released from the mast cells and the basophils the first time an allergen is introduced into the body without the patient ever being sensitized. The antigen causes the release of chemical mediators. This reaction, in which no sensitization is required, is referred to as an anaphylactoid reaction or a non-IgE mediated reaction. The body's response, which is bronchoconstriction, increased capillary permeability, and vasodilation, and the signs and symptoms are the same for an IgE-mediated anaphylactic reaction. Okay. Alright, allergens can enter the body through injection, ingestion, inhalation, and contact. Okay? Absorbed through the skin. Types of allergens include Venom from insect bites or stings. Usually millipedes, caterpillars, centipedes most often cause local reaction. Foods including peanuts, other nuts, milk, eggs, shellfish, whitefish, food additives, chocolate. I would hate to be allergic to chocolate. Jesus. No. Cottonseed oil and berries cause anaphylactic reaction in some people. Pollen from plants, especially ragweed and grasses, can cause anaphylactic reaction. Medications including antibiotics, local anesthetics, aspirin, seizure medication, muscle relaxants, non-steroidal anti-inflammatory agents, also and vitamins are known to cause anaphylactic reactions in some patients. Insulin and tetanus and diphtheria toxoids can also produce an anaphylactic reaction. Pretty much anything you're exposed to can produce an anaphylactic reaction. Okay? Glue, hair dye, nickel, henna tattoos, and transfused blood can also produce reactions. Exercise can accentuate the anaphylactic response when certain foods have been ingested close to the time of exercise. Alright, you'll see these in dedicated athletes such as myself. Why y'all laughing? Huh? What now?
So like the transfused blood, is that just like someone that doesn't have the same blood type? Is it just blood, period?
Yes and no. There's so many things that go into transfusing blood. So, yes and no on that. Latex is often found in examination gloves and other medical devices, and there are a lot of people allergic to latex. Matter of fact, you'll meet lots of medics and nurses that have developed a latex allergy after wearing those things for so long. Most of the gloves and stuff used now are non-latex based. Okay. An anaphylactic or anaphylactoid reaction can be triggered by many substances. All right. Most common cause is medication that are either taken or injected. We already talked about most of these. Aspirin. In the African American community, all right, lisinopril. I don't know what it is about lisinopril, but it causes a lot of problems in the African American community. Okay, it causes very bad angioedema. So if you go to somebody that has swelling of the throat, the mouth, you need to ask them, did you take lisinopril? Did you take any of the prils? Okay. I actually, when I first got on blood pressure medicine, was taking lisinopril. It didn't make my throat swell up. It made my stomach hurt so bad I could not function. So I got off it. Huh? Do you? Oh, it made me so sick. So freaking sick. Alright. Perfumes. Perfumes are a big thing. Okay, we don't wear perfumes to work for that reason. Alright, during the scene size up, you must be certain that your own safety is not in jeopardy, especially if the anaphylactic reaction is the result of a bite or sting. You might encounter a patient who disrupted a yellow jacket or wasp nest and was stung several times. Yeah, that's what I'm thinking too. I'm be like, you better come on over here to this truck. The yellow jacket or wasp can still be at the scene and will attack you when exiting the ambulance, exposing you to the risk of an anaphylactic reaction from the sting. If you detect the presence of a mini wasp or yellow jackets, you might have to wait until they settle or disperse before approaching the patient. Or, if your patient's that bad off, they can crawl right on over to that truck, okay? Because that scene is not safe.
Yeah, you send the police up. Yeah, send the police to go clear it.
Yeah, good luck with that. That's a call for the fire department because they can take that water hose and just spray the scene down. Yeah, that's going to be a fire department thing right there. Because so many different substances can cause an anaphylactic reaction, the scene size up might not provide any obvious clues to the nature of the illness. In gathering your general impression of a patient with an anaphylactic reaction, you might note that they complain of not feeling well, or malaise, or generalized feeling of weakness or discomfort. Such a patient can display a sense of impending doom. He may also complain of difficulty swallowing or itching or tightness of his throat. The patient's mental status can be anywhere on the continuum from responsive to responsive but disoriented to unresponsive. Closely assess the airway for signs of obstruction, stridor, hoarseness, or crowing sounds indicating significant swelling to the upper airway. Inserting an airway adjunct might not help relieve the obstruction if the swelling is at the level of the larynx. You might also find a swollen tongue that interferes with the airway. It might be necessary to provide positive pressure ventilation to force air past the swollen upper airway. You might also find a swollen tongue that interferes with the airway. Wheezing can be prominent upon assessment of breathing. If the patient is severely disoriented, unresponsive, or breathing inadequately, immediately begin the positive pressure ventilation with supplemental oxygen. If their breathing is adequate and they have an SpO2 of, y'all are amazing. Good. The pulse in a patient suffering from anaphylactic reaction can be weak and rapid. The rapid pulse might not be present because of the low blood pressure. Edema or swelling may be obvious in the face, neck, lips, tongue, hands, and feet. The skin can be red and warm, or the patient's skin can be cyanotic from inadequate breathing. You might notice hives or raised red blotches all over the skin. This lady right here probably took some lisinopril because that is localized angioedema. Yeah.
That is some massive swelling.
Yep. All right, this is what hives and urticaria looks like. It's from a food allergy, and they itch really, really bad. Like you want to claw your skin off. Okay. Some of the signs and symptoms include rhinitis. What is rhinitis? It does not have anything to do with a rhinoceros. Okay. Tachycardia. Pruritus. Faintness. All right. They can also have warm flushed skin, agitation, anxiousness, edema. All right, that swelling that we talked about. Because of the potential seriousness of an anaphylactic reaction and its effects on the airway, lungs, blood vessels, and heart, the patient is considered a priority and should be prepared for immediate transport. Okay, these are not the ones you want to stay on scene and play with. These are your load and goes. Before leaving the scene, determine whether the patient has a prescribed epi auto-injector. Inquire relatives or any bystanders if the patient is unresponsive. All right, here's your signs and symptoms. Yep. Here's most signs and symptoms. All right, the secondary assessment should be conducted whether the patient's signs and symptoms indicate a mild, moderate, or severe reaction. However, the patient exhibits signs of a severe reaction, do not delay transport of the patient to complete this secondary assessment. If you do, you will probably kill them. All right, determine the following. Are their signs and symptoms consistent with an anaphylactic reaction? Do the signs and symptoms indicate mild, moderate, or severe reaction? Are they getting worse or are they getting better? Is the patient experiencing dyspnea or chest pain? Patients sometimes complain of shortness of breath and chest pain before any of the other signs and symptoms of anaphylaxis occurred. Allergies. Does the patient have a history of allergies to food, medicine, plants, insects, stings, or bites, or other things prior to this anaphylactic reaction? If so, what was it? Does the patient have an epi auto-injector? Has the patient taken any medications to relieve the current signs and symptoms, including over-the-counter medications such as Benadryl? What other medication is the patient taking? Does the patient take a beta blocker? If the patient is taking a beta blocker, their response to epinephrine may be limited. Remember your beta blockers end in OL, metoprolol. The only one that comes to mind right now for some reason. All right. Past history. Has the patient suffered an anaphylactic reaction in the past? How severe was it? Did they have any other significant illnesses? When was the last time the patient had anything to eat or drink? What did they eat or drink? How much food or drink did the patient consume? What was the patient doing prior to the onset of this reaction? What was the patient's exposure to? What was the route of exposure? Injection, ingestion, inhalation, or contact? All right, check their skin out. Could be warm, tingling in the face, mouth, chest, feet, hands. Intense itching, especially the hands and feet. Flushed or red skin. You'll see the hives. This is your hallmark sign for this. Okay? Hives. Swelling of the face, lips, neck, hands, feet, and tongue. Cyanosis. They will complain of a lump in their throat, tightness in their chest, have a high-pitched cough. Tachypnea. Labored breathing, noisy breathing. They'll have wheezing, stridor, crowing. Impaired ability to talk or hoarseness. Excessive amounts of coughed up mucus, partially or completely occluded airway. Difficulty in breathing. They will be tachycardic, hypotensive, irregular pulse, and sometimes they will have a absent radial pulse. Okay? They will have increased anxiety, lightheaded, unresponsive, disoriented, restlessness, seizures, headache. All right, they can have nausea, vomiting, abdominal cramping, diarrhea, difficulty in swallowing, loss of bowel control. They may have an urgent need to urinate and cramping of the uterus. If you're a man, I would not think you would have cramping of the uterus, but I could be wrong. Itchy, watery eyes, running or stuffing nose, sense of impending doom, complaints of not feeling well, and generalized weakness and discomfort. I just scratched the bejesus out of myself. Over here talking about all this itching and stuff. Alright, assess the vital signs, paying attention to the breathing, pulse, and blood pressure. The respiratory rate can be beyond the normal limits. Early in anaphylactic reaction. You might find that the respiratory rate is fast and labored. As the condition progresses and the patient begins to tire, the breathing can become slower than normal and shallow. Wheezing can be heard without a stethoscope. The breathing can also sound noisy, with a rattling sound on inspiration and exhalation from the excessive mucus in the lower airways. The pulse is rapid and can be weak. In severe cases of anaphylaxis, the radial pulse can be absent or extremely weak. Unlike other types of shock, the skin is usually red, dry, and warm to the touch. Hives and itching are the most common complaints in all types of allergic reactions, mild, moderate, and severe. Hypotension is common in severe reactions. All right, so we need to distinguish between a systemic reaction and a local reaction. A systemic reaction is known as what? Anaphylaxis. Okay? A local reaction is just a allergic reaction. Okay? So, your treatment is going to depend on this distinction. The local reaction typically does not require aggressive intervention or administration of medicine by the EMT. In a patient with a local reaction, you can maintain adequate oxygenation and transport the patient while constantly assessing for signs and symptoms of a systemic reaction. Epinephrine should be administered to patients with signs and symptoms of systemic reactions, especially if they present with hypotension, respiratory distress, or upper airway edema. Your major concern is that the mild local reaction can rapidly progress to a moderate to severe or anaphylactic reaction, and you need to be prepared to manage the worst case scenario and continuously reassess. Alright, so you have an acute onset and signs and symptoms of respiratory distress and or signs and symptoms of poor perfusion or hypotension. Okay? You have to have at least two of these. You have to have an acute onset. It's got to involve the skin, mucosal tissue, or both. Hives, itching, flushing, redness, edema to the face, lips, and tongue. And signs and symptoms of respiratory distress. Poor perfusion, hypotension. Does everybody understand that? You go to a call, somebody took ate a peanut, and they have itching. Are you going to pop them with an EpiPen? No. Okay? They're breathing fine, their heart rate's fine, everything's fine, they're just itching a little bit. They do not get Epi. Alright? Alright. With an anaphylactic reaction, you want to maintain the airway. Airway adjuncts may not be effective. You need to suction secretions and maintain their SpO2 at 94% or greater. You want to be prepared to assist with ventilations. Okay? Administer Epi in any patient with signs and symptoms of a severe systemic anaphylactic reaction, especially when the patient presents with hypotension, respiratory distress, or upper airway edema. Obtain an order from medical direction to administer Epi. This is typically done by an Epi auto-injector. All right, consider calling for advanced life support because these people can rapidly deteriorate. Initiate early transport. Do not unnecessarily delay transport of the patient. All right, you put that patient on the stretcher and pop them in the thigh on the way to the hospital. All right. Reassessment is critical in the management of mild, moderate, and severe allergic reactions. The patient with local reactions should be constantly monitored for indications that the reaction is worsening and that further interventions such as Epi injection or airway control might be needed. The patient who has received an Epi injection should be reassessed to determine whether the injection has been effective in reversing the life-threatening condition. You want to reassess the patient every 2 minutes after the injection of epinephrine. Look for improvement in the patient's ability to breathe, improvement of his mental status, an increasing SpO2 reading, and an increase in the blood pressure. And y'all, this can happen very, very quickly. They turn around pretty quick, to be honest. A biphasic reaction that occurs when initial signs and symptoms revolve, sometimes without treatment, if not severe, and then approximately 4 to 6 hours later, a second reaction occurs. The signs and symptoms of the second reaction could be life-threatening, even if the first reaction was not. All right, Epi is the drug of choice for the emergency treatment of systemic allergic reaction to insect stings or bites, food, drugs, and other antigens. The drug mimics the response of the sympathetic nervous system. Epi has 4 properties: alpha-1, alpha-2, beta-1, beta-2. Alpha-1 causes the vessels to constrict. Alpha-2 regulates the amount of vasoconstriction. Beta-1 increases the heart rate, force of contraction of the heart, and the speed at which the electrical impulses are carried through the heart. Beta-2 causes the bronchial smooth muscle to dilate. 3 of the major responses to the chemical mediators by the body causing the life-threatening anaphylactic condition are increased capillary permeability, vasodilation, and bronchial constriction and inflammation. Epi's alpha properties cause vasoconstriction and tightening of the capillaries, reversing the vasodilation and increasing capillary permeability experienced by the anaphylactic patient. The beta-2 properties cause vasodilation, reversing the bronchial constriction. The beta-1 properties are responsible for side effects from administration. Also, Epi has a direct antihistamine effect, reducing the effect of the actual histamine. The body's response to Epi is rapid. Within seconds, the patient will begin to feel relief. I never believed that until I actually saw it. Okay. However, the duration of the drug's effectiveness is short, only approximately 10 to 20 minutes. Both epinephrine auto-injectors and the EpiPen and the Avi-Q come in different doses. The 0.3 milligram dose for Epi is for patients weighing 66 pounds or greater. The injector for infants and children weighing 33 to 66 pounds delivers 0.5 milligrams of epi. A child who weighs more than 66 gets the adult dose. Comes in a package of disposable delivery systems for self-administration. Common systems prescribed to patients are the EpiPen. I have some in my desk. Do not open these because they are not trainers. Just FYI. You do not want to stick yourself with this. It will be very, very, very bad. The dose can be repeated in 5 to 15 minutes if the condition does not improve. Alright? Some of the side effects are increased heart rate, pale skin, dizziness, chest pain, headache, nausea, vomiting, excitability, and anxiousness. Administer an epi-auto pen. Establish and maintain an open airway. Put some oxygen on them. Remove the safety cap from the epi-auto injector. Place the tip of the auto injector on the anterior lateral aspect of the thigh, midway between the hip and the knee. You can also give this through clothing. The needle is long enough. Push the injector firmly against the thigh until it activates. Hold it in place until the medication is injected. Don't just hit them and quit them. You got to hit it and leave it in place. Then you want to dispose of it in a Sharps container. Record the time and reassess the patient. Luke and Joy quickly gather information to confirm their initial impression of anaphylaxis. Jessie has an epi auto-injector in the nurse's office, but the nurse is not currently at the school. Where else would she be? As Joy reassures Jessie and completes a rapid secondary assessment, including vital signs, Luke confirms that the auto-injector is prescribed to Jessie and administers it. Recognizing the short duration of action of epi, the EMTs do not spend further time at the scene to transport immediately. Jesse's wheezing decreases en route, and there is no worsening of his swelling or rash. His blood pressure remains normal as well as his SpO2, although his heart rate has increased from 104 to 116. Is this something we need to worry about? No, it's going to be a side effect of the epi, okay? And that, he's probably scared to death. At the emergency department, Jesse receives additional epi, as well as an antihistamine. After being observed and monitored for several hours, Jesse's parents are grateful to be able to take him home. Usually, they will give you the epi. They will give you the Benadryl, and usually something for your stomach. You have histamine receptors in your stomach and your GI tract as well. So they'll usually give you like Pepcid, Zantac. I think it's Zantac. They usually give you IV for that.